Dr. Nagesh, Dr. Bhumika, and Dr. Kuldeep Dabla. You please are welcome and take the session. Our NICU is almost 80% of the babies coming to NICU present with respiratory distress. So I am giving a brief talk on that. So we start from the history. Like any baby coming to NICU, we take the history, whether it was a premature delivery. Premature delivery, we want to rule out HMD. Post-mature delivery, we rule out any meconium aspiration. I will just telling the common thread. Any meconium state like a history of GDL, again a risk of HMD is there. Oligohydramnios, risk of lung hypoplasia is there. Polyhydramnios associated with acute fistula, acute decreased fetal movements. They are like mitigation of certain neuromuscular disorders, congenital myasthenia, traumatic deliveries, any drugs, any sedatives to the mother, or any history of antenatal steroid, which is required for lung maturation. Cesarean section, again risk of PTN, any risk of antepartum hemorrhage, that again risk of aspiration. Then coming to the examination. The major signs are the baby presents with cyanosis, tachypnea, grunting, retractions, nasal clearing, stridor, wheeze, hoarseness, and other airway findings. Cardiovascular assessment, blood pressure assessment, neurological assessment, abdominal assessment, chest wall assessment, and temperature assessment. I will come into detail one by one. Then laboratory workup, we do chest X-ray, blood gas, blood glucose, hematocrit, total count, differential count, integrated blood culture info, and other diagnostic info. Okay, this is a short flow chart. First, we do the X-ray. If it is abnormal, then commonly first thing is the HMD. Then TPN, aspiration pneumonia, can be air leaks, effusion, pulmonary edema. Uncommon causes can be diaphragmatic hernia, tracheoesophageal fistula, any thoracic cyst, tumors, lung hypoplasia, pulmonary hemorrhage, congenital local emphysema, infantasia, sequestration, AV fistula. If X-ray is normal, then we have to look for blood pressure, hematocrit, upper or lower airway obstruction, any cardiac problem, neuromuscular problem, chest wall deformity, diaphragmatic abnormalities, and also we have to look at the abdomen. Okay, so first is the abnormal X-ray with a common finding. One is the respiratory distress syndrome. So it will be this is the X-ray of RDS, HMD, meconium aspiration. Okay, so RDS will present by reticogranular pattern, brown glass opacity, air bronchogram, and decreased lung volume. In PTN, there will be fluid in the major fissure, pneumonia, yawn will be presenting with infiltrate, and meconium is presented with port opacity. This is port opacity. And this is the picture of hypoplastic lungs. Then this is congenital local emphysema. We have the infection on that side and the diastema is on the other side. Then uncommon findings can be diaphragmatic hernia, tracheoesophageal fistula, thoracic cyst and tumors, congenital emphysema, pulmonary hypoplasia, pulmonary hemorrhage, sequestrated lobe, lymphadenopathias and fistulas. This is X-ray of meconium aspiration syndrome with pneumothorax. Then small right side pneumothorax. Then this is pneumopericardium. This is pneumomediastinum. So then air leaks, as I told you, pneumothorax, AIE, pneumomediastinum, pneumopericardium, pneumoperitoneum. This is cystic adenomatous malformation. The right side. This thoracic cyst, so teratoma, cystic adenomatous, they are very rare, and we need chest CT for that. This is pneumonia. Organisms which cause pneumonia, neonate, legally, bacterial, GBS, E. coli, Klebsiella, staph aureus, staph epidermidis, Listeria, Enterobacter, influenza, staph pneumoniae, Pseudomonas, Bacteroids, viral, CMV, then adenovirus, rhinovirus, RSV, influenza, enterovirus. Then this is the fungi, Candida, Xeroplasma, Mycoplasma, typical organisms. Then Pneumocystis carinii. Pleural effusion can present with hydrothorax in cases of hydrops fetalis, with congenital tumors, pneumonia, congenital viral infections, congestive heart failure, transient tachypnea also rarely, and Turner syndrome. Pylothorax can be spontaneous or complication of thoracic surgery. Pneumothorax can be traumatic or a ruptured vessel in cases of DICS, sepsis, and other bleeding disorders. And complication of central line placement can also cause. Then abnormalities in perfusion. You have to look for anemia. Polycythemia can present as respiratory distress. Anemia can present even hypotension, hypovolemia. This diaphragmatic disorder due to chronic nerve failure. This is the diaphragm on the right side. Then neuromuscular abnormalities. The cases presenting with birth asphyxia, intracranial hemorrhage, congenital neuromuscular disorders, any other on any drug. Myopathy, myasthenia gravis, SMA, spinal cord disorders, poliomyelitis. This is abnormality of diaphragmatic hernia. The abdominal contents are in the chest, thoracic cavity. So, diaphragmatic disorders and chest disorders. Diaphragmatic hernia, congenital debilitation of diaphragm, diaphragmatic paralysis, diaphragmatic defect, neuromuscular disorders. Then chest wall disorders, very rare to be seen. Failure of sternal fusion and excessive creative thoracic dystrophy, chondrodysplasia, then achondrogenesis, osteogenesis imperfecta, very rarely we see. And then airway abnormalities can be upper airway, laryngeal or lower airway. Upper airway can be coagulopathy, stenosis, trauma to the upper airway, hemangioma, steratoma, encephalopathy, cystic hygroma, pyroprocessor, micrognathia, rectognathia, benign and malignant tumors of the upper airway. Laryngeal can be laryngomalacia, vocal cord palsy, hemangioma, atresia, webs in the larynx, congenital laryngeal present with congenital laryngeal stridor. Then any cystic lesion, benign and malignant tumors in the larynx. Then lower airway can present with tracheoplacia, tracheoesophageal fistula, hemangioma, congenital tracheal stenosis, bronchiectasia, any benign and malignant tumors. See this heart defect, gastrocardia with congenital heart disease. Can present with respiratory distress. That's right. This EGA with agon side appearance on the X-ray. So abnormal congenital heart disease with persistent fetal circulation, cyanotic congenital heart disease, and obstructive congenital heart diseases and congestive cardiac failure. This abdominal findings, babies with ascites can present with respiratory distress, babies with necrotizing enterocolysis, any abdominal mass, omphalopathy, gastroenteritis. Out of them, most commonly we see neck only. Other anomalies, not anomalies, just other associated conditions. Respiratory distress can present with sepsis, acidosis, hypothermia, hyperthermia, hypoglycemia, with hemoglobin. Then management depends on the cause actually. Basic management is maintenance of airway, oxygenation and removal of carbon dioxide, maintaining blood pH and adequate cardiac output. Surgery required in case of pneumothorax, any cysts in diaphragmatic eruption surgery is required. Supportive therapy, lead thermal regulation, nutrition, fluid and electrolyte balance, and antimicrobial therapy in case of any infection. So now I will speak briefly about non-invasive ventilation kit, by which we are managing respiratory distress in our NICU, in our DCH Hisar. So this ventilation was discovered in 1960s. Okay, initially was intermittent positive pressure ventilation, and many babies survived because of that. But the adverse effects, face mask, nasal mask, and nasal prongs. Now we are using nasal prongs. Nasal CPAP briefly is a non-invasive method of applying constant distending pressure to the lungs via the nostril. So CPAP preserves spontaneous breathing, does not require endotracheal intubation, and results in less lung injury than mechanical ventilation. we start CPAP in the delivery room only in premature babies. So they reduce the risk of treatment failure. Means they reduce the risk of apnea, hypercarbia or hypoxemia, requiring rescue CPAP or mechanical ventilation later on. So it is advised to start CPAP directly in the labor room in preterm babies. Then also after extubation in preterm babies, if we give CPAP compared to oxygen by hood box, there is reduced incidence of apnea, respiratory acidosis and hypoxemia. But it did not change the rate of endotracheal intubation. Next is high flow nasal cannula, which now we are using in our anesthesia. They are small, thin, tapered binasal tubes which deliver oxygen or blended oxygen and air and has flows of more than 1 liter per minute in preterm babies. We use humidified gas. So how it works? It functions by oxygen delivery and CO2 washout in pharynx. But also high flow can give standing pressure equal to CPAP to open up the alveoli. So if we compare high flow and CPAP in initial management of RDS, there is no difference in the rates of death or bronchopulmonary dysphagia, or we used to call it chronic lung disease. Okay, and rates of reintubation within first week are also not significantly different. So after extubation, there is no much difference in CPAP and high flow, but high flow reduces the rate of nasal trauma and pneumothorax as compared to CPAP. So nowadays we are preferring high flow here in our country. Next is NIV, because non-nasal intermittent positive pressure ventilation, in which patients are exposed to intermittently higher levels of airway pressure and also maintaining the peak through the CPAP. So this one we have one machine but still is not working. So this we have to fix through the ventilator. So limitations of flow sensor. Means the negative effect is that the flow sensor will not work if we use the NIV. So we cannot synchronize the breaths. So NIV versus CPAP for initial management of RDS, NIV decreases rates of respiratory failure and need for reintubation. There is no change in risk of death or BPD later on. So, and after extubation, NIV reduces the extubation failure and reintubation at 48 hours and 7 days post extubation. And also NIV showed decreased incidence of ARDS. So definitely NIV is better than CPAP. Now, summary, CPAP is in the premature, it is reasonable to manage very premature babies by CPAP. It reduces mortality and bronchopulmonary dysphagia compared to mechanical ventilation and also reduces respiratory instability. If we use NIV with CPAP, it augments the benefit of CPAP. And high flow and CPAP is almost equal, although the risk of trauma and pneumothorax is less with high flow. So I will place NIV on top, then high flow, then CPAP.
The only thing I would just like to add, I think, is covered the basics of respiratory distress, and it's very common. It's almost something that we see every day in our NICU, or I'm sure people who come from outside. The important thing, I think, especially for a lot of students that we have here, it's important that when you have a patient who's come with respiratory distress, it's important to think about the basics, like the most common causes, like Sir mentioned. It is also important that don't forget there are other causes as well. So if you have, okay, this is HMT and we're not thinking anything else, that's also wrong. I mean, and X-ray gives us a lot of picture of what it can be, so look at the X-ray properly. Everything is not pneumonia. The problem is whenever we get an X-ray, the first thought is pneumonia. It is very important that we assess the patient, and by the time we get our X-rays, by the time we get all our reports, I think we have some reading in our mind. It's the whole idea of this PPT, I think, is to know that there are so many differential diagnoses. So I think that was put very nicely in your PPT. So thank you so much, Dr. Samarth.
Thank you, Dr. Arora and the Paediatrician at DCH. Any more questions, please? The mementos to the speaker. And I also invite all the chairpersons on the stage, Dr. Rajendra Dugesar, Dr. Nagesh, Dr. Bhumika. We will now felicitate our chairpersons, Dr. Rajendra Dugesan, is a pediatrician at DCH Hisar. Thank you, doctor. Imparting his services as Deputy Civil Surgeon Medical Seat, Dr. Kuldeep Karla.
Audience, please
Dr.
give your
Bhumika.
claps. Breakfast का रखा है सबने. Lunch तक
Thank you
एनर्जी
for
चलनी
the
चाहिए.
Dr. Bhumika. Hisar. Thank you, Dr. Nagesh. And I thank Dr. Prabhudyal for his esteemed services. Thank you, sir.